LDN titration in canary patients. Start low, go slow protocols for MCAS, ME/CFS, and autoimmune disease. Yoon Hang John Kim, MD, author of LDN Primer, now available on Amazon. Board-certified preventive medicine, integrative and functional medicine, LDN Research Trust presenter, the short version. If you've been told LDN will make you better, but every dose so far has made you worse, you aren't broken and you aren't a bad responder. You may be a canary patient, exquisitely sensitive, with a depleted endorphin reserve. For canary patients, the standard 1.5 to 4.5 milligrams climb is too much, too fast. The fix isn't abandoning LDN. It's starting much lower, sometimes in micrograms or nanograms, and moving much more slowly. This piece walks you through how I think about it in clinic. I've been prescribing low-dose naltrexone for over 2 decades. In that time, I've learned that the patients who do worst on standard protocols are very often the patients who need LDN the most. They show up with mast cell activation syndrome, MCAS, myalgic encephalomyelitis/chronic fatigue syndrome, ME/CFS, long-standing autoimmune disease, mold or Lyme histories, post-viral illness, or some combination. They're the canaries. And like the canaries miners once carried into coal shafts, their bodies are picking up on something the rest of the room doesn't feel yet. That sensitivity is information. The clinical task is to honor it. Who is a canary patient? Canary isn't a formal diagnosis. It's a description of a clinical pattern I see all the time. Canary patients tend to share most of the following: years, often decades, of complex, layered illness rather than a single recent diagnosis. Multiple drug or supplement intolerances. They react to things other patients tolerate without a thought. A pattern of paradoxical reactions. Small doses cause big symptoms. Starter doses feel like overdoses. MCAS features: flushing, hives, food, and odor sensitivities. GI symptoms: dysautonomia. Post-exertional malaise. Even mild activity is followed by a crash, often delayed by a day or two. A profound loss of resilience. Colds linger, stressors don't bounce off, sleep doesn't restore. What ties these features together, in my view, is a depleted endorphin reserve. The body has been running on emergency reserves for so long that it has very little buffer left. Introducing anything that touches the opioid system, even a small dose of LDN, can feel destabilizing. Endorphin reserve, in plain language. Endorphins are your body's own opioid-like chemicals. They help with pain, mood, sleep, immune balance, and resilience under stress. Think of them as the vitality currency your nervous system spends every day. When you're healthy, the account refills overnight. When you've been ill for a long time, you're running an overdraft. In traditional Chinese medicine, this kind of deep reserve is called Jing. In Ayurveda, it's Ojas. Different languages, the same idea. A measurable by feel sense of how much vital capacity you have left in the tank. LDN works in part by encouraging your body to make more of its own endorphins and to use them more effectively. That's wonderful for a patient with reasonable reserves to start with. For a canary patient with very little reserve, the same nudge can feel like running an engine that's already overheating. This is why I almost never start a canary patient at 1.5 milligrams. Often, I start 100 times lower, sometimes 1,000 times lower. The goal isn't a bigger dose, it's the smallest dose that wakes up the system without overwhelming it. The Kim LDN Optimal Dose. Questionnaire trademark. Before prescribing the first dose, I ask every patient 5 questions. I've refined this in clinic over many years, and I now call it the Kim LDN Optimal Dose Questionnaire. It's not a lab test. It's a structured way of estimating how much endorphin reserve you have to work with, and therefore where to start. Hash. Question. What I'm listening for. 1. How long have you been sick? Decades of illness suggest deeper reserve depletion than a recent diagnosis. 2. Do you wake up restored? Non-restorative sleep is one of the loudest markers of depleted endorphin function. 3. What is your energy like across a normal day? Crashes, post-exertional malaise, and an inability to push through all point to low reserve. 4. How quickly do you bounce back from setbacks, an infection, a stressor, a bad week? Slow recovery from ordinary insults is a resilience problem, not a willpower problem. 5. Can you still work, exercise, parent, or run your daily life? Functional capacity is the practical, day-to-day proxy for endorphin reserve. I'm not assigning a numerical score. I'm listening to the texture of the answers. A patient who has been ill for 15 years, sleeps poorly, runs on caffeine to make it to lunch, crashes for 3 days after a short walk, and stopped working. 2 years ago is in an entirely different place from a patient with a recent autoimmune diagnosis who still hikes on the weekends. Both may benefit from LDN. They should not start at the same dose. Start low, go slow. Titration tables for canary patients. Most LDN information online describes a fast climb to 4.5 milligrams over 2 to 4 weeks. That's a reasonable starting point for a more robust patient. For a canary patient, it can be a setup for a flare. Below is how I actually think about the dose ladder. Table 1. The LDN dose ladder. Category. Dose range. Who it tends to fit. Standard LDN. 1.5 to 4.5 milligrams, sometimes up to 10 milligrams. A patient with reasonable energy and resilience, a clear diagnosis, and no history of paradoxical drug reactions. Very low dose. VLDN. 10 micrograms to 500 micrograms, or 0.5 milligrams. A patient who can usually tolerate medications but has been sick a long time or has had side effects on a typical starting dose. Ultra-low dose, ULDN. 1 to 100 micrograms, MCG. Most canary patients land here, MCAS, ME/CFS, long-standing autoimmune disease, post-viral illness, mold/Lyme, nanogram dosing, below 1 microgram in the nanogram range. Reserved for the most sensitive patients who react even at 1 microgram. Requires specialty compounding or careful self-dilution. At 1 microgram, naltrexone barely tickles the opioid system. It can still act as a hormetic signal, a small biological nudge that asks the body to make more endorphins without overwhelming the receptors it's trying to support. Table 2. Where I start and how slowly I climb. Patient picture. Starting dose. How often I increase. Standard patient, moderate illness, 1.5 milligrams. Toward 4.5 milligrams over 2 to 4 weeks. Severely ill or low functional capacity, 0.5 milligrams or lower, every 2 to 4 weeks, in small steps. Canary patient, MCAS, ME/CFS, complex autoimmune. 10 micrograms to 100 micrograms, every 4 weeks or longer. Some patients need 6 to 12 weeks between increases. Extreme sensitivity, reactions at 1 microgram. Nanogram range. Every 1 to 3 months. Patience is the medicine. Children. Microgram dosing. Very slow, individualized titration. Side effects appear at any dose. Drop back to the last well-tolerated dose. Hold longer before trying to advance again. 2 practical points families ask me about. 1. Compounding matters. Microgram and especially nanogram doses are not standard pharmacy stock. They require a compounding pharmacy that is genuinely comfortable working at this level. If your pharmacy hesitates, find one that doesn't. 2. Liquid is usually easier than capsules at this level. Liquid LDN lets us make small, precise changes without reordering capsules every week. For very sensitive patients, this flexibility is the difference between staying on therapy and quitting in frustration. What the science actually says, the honest version. LDN is one of my favorite tools. It is not magic. Anyone selling it as a sure thing is overselling. On the encouraging side, the early fibromyalgia studies by Younger and colleagues at Stanford showed about a 29% reduction in pain on 4.5 milligrams of LDN compared to roughly 18% on placebo. A retrospective analysis at the Mayo Clinic of 115 patients found that about 65% of those on LDN for chronic pain reported some benefit. In ME/CFS, a retrospective analysis from Finland of 218 patients reported that nearly 3/4 experienced a positive response to 3.0 to 4.5 milligrams LDN over an average follow-up of about 1.7 years. On the sobering side, the final trial published in Lancet Rheumatology in 2024, the largest randomized controlled trial of LDN in fibromyalgia to date, did not show a statistically significant pain reduction over placebo at 6 milligrams. A larger proportion of patients on LDN achieved at least a 30% pain reduction than on placebo, and memory symptoms improved, but the primary endpoint was negative. That deserves to be said out loud, not hidden in a footnote. Two truths can sit side by side. Some patients respond beautifully to LDN. Roughly 1 in 3 patients does not respond to standard protocols at all. The canary population sits right at that fault line, which is exactly why dose strategy matters so much. What this looks like by condition. Mast cell activation syndrome, MCAS. MCAS. Patients are often the most reactive of all. In a published BMJ case report, a severely affected patient with both POTS and MCAS could not tolerate ordinary LDN escalation. Her physician started her at 1 milligram at night rather than climbing to 4.5 milligrams. That ultra-low dose improved her pain, mood, sleep, flushing, food, and odor sensitivities, and limb tingling, and became a core part of a regimen that returned her to a near-normal life. In my own practice, almost every MCAS patient starts in the microgram range. We usually pair LDN with a true mast cell stabilization plan, a clean low-histamine baseline, keto-typhon, cromolyn, sometimes methylene blue with metabolic support, as I describe more fully in the LDN primer. LDN by itself is rarely enough. LDN inside a thoughtful MCAS protocol is often transformative. Myalgic encephalomyelitis/chronic fatigue syndrome, ME/CFS. ME/CFS. Patients almost always have profound post-exertional malaise. They cannot afford to push through an LDN side effect. If a 1.5 milligram starting dose causes vivid dreams, insomnia, or a flare, they may be set back for weeks. Research from Cabanas, Marshall Gradisnik, and colleagues at the National Center for Neuroimmunology and Emerging Diseases has shown that naltrexone may help restore impaired ion channel function, TRPM3, in natural killer cells from ME/CFS patients. That gives a plausible biological reason behind the clinical signal Polo and colleagues reported in their 218-patient series. It also tells us we're working on a delicate system. Slow titration honors that. Autoimmune disease. For autoimmune patients, Hashimoto's, lupus, rheumatoid arthritis, multiple sclerosis, Crohn's disease, psoriasis, and others. LDN's appeal is its capacity to calm immune dysregulation without the side effect burden of conventional immunosuppression. Small randomized trials have suggested quality-of-life benefits in MS, and a placebo-controlled trial in active Crohn's disease showed improvement in mucosal healing on LDN. Autoimmune patients who are otherwise functional often tolerate standard 1.5 to 4.5 milligrams titration well. Autoimmune patients with overlapping MCAS, ME/CFS, mold, or Lyme histories almost never do. The same diagnosis can hide two very different metabolic situations. That's why the questionnaire matters more than the diagnostic label. What you should expect on a canary patient protocol. It will feel slow. That is the protocol working, not the protocol failing. A canary protocol can take 3 to 6 months to find a stable, effective dose, sometimes longer. Vivid dreams and short-term sleep changes are common, even at very low doses, and usually settle. Nightmares in patients with significant trauma history are a reason to pause and reassess. Symptoms may flutter before they improve. Mast cell symptoms, fatigue, or pain can wobble in the first few days after each dose change. If you feel worse and it doesn't resolve in a few days, the answer is almost always to step down, not to power through. Drop to the last well-tolerated dose and stay there. Roughly a third of patients won't respond meaningfully to LDN at any dose. If you're in that group, you're not failing the medicine. The medicine is showing you that the work is somewhere else. LDN is a tool, not the whole toolbox. Canary patients almost never get fully well on LDN alone. In my experience, LDN often does what nothing else has done. It lowers the noise enough that other treatments finally have a chance to work. That might mean mast cell stabilization, a careful look at mold or Lyme, mitochondrial and metabolic support, hormone balance, sleep repair, trauma-informed nervous system work, or whatever your particular root causes turn out to be. If you'd like the longer version of this framework, including the dosing categories, how I assess endorphin reserve in detail, when to consider higher dose naltrexone, and the MCAS stacking protocol, it lives in the free LDN primer at the low-dose naltrexone support group and is expanded with case material in my book Low-Dose Naltrexone, 2 decades of clinical observation and review of current research. Bottom line for canary patients. You are not too sensitive. You are accurately sensitive. Standard protocols were not designed with you in mind. The right starting dose for you is probably much lower than the internet suggests, and the right pace is much slower. Work with a clinician who knows how to dose in micrograms and nanograms, who can compound or refer to a pharmacy that can, and who will be patient with you while your system relearns how to rest. About the author. Yoon Hang John. Kim, MD, MPH, FAAMA, is a board-certified preventive medicine physician practicing integrative and functional medicine. He completed Dr. Andrew Weil's Integrative Medicine Fellowship at the University of Arizona and is an Institute for Functional Medicine certified practitioner. Dr. Kim has prescribed LDN since the early 2000s, has presented at multiple LDN Research Trust conferences, and has authored 3 books on LDN. He sees patients via telemedicine through direct integrative care in Iowa, Illinois, Missouri, Georgia, Florida, and Texas, and in person at Hill Country Integrative Medicine in Fredericksburg, Texas. Clinical practice, directintegrativecare.com. Physician mentoring, yoonhangkim.com. Refer to Dr. Kim's new book, LDN Primer, on Amazon.